Today we're going to be asking or talking about predicting progression of myelofibrosis with Dr. Gaby Hobbs. And this is a really good topic because it's one that comes up often when speaking with patients. And joining us for this topic is Dr. Gaby Hobbs. Dr. Hobbs is a hematology oncology physician who specializes in the care of patients with myeloproliferative neoplasms, such as myelofibrosis, chronic myeloid leukemia, chronic myeloid leukemia, and leukemias. She is an active clinical researcher and lead MPN research program at the Mass Gen Hospital. She has led several clinical trials and participated in translational research for MPNs. In addition, Dr. Hobbs, the clinical director for adult leukemia services at Mass Gen. Dr. Hobbs strives to provide compassionate care for each patient and their family and works to tailor therapies to meet each individual patient's needs. Thank you for joining us today, Dr. Hobbs.
My pleasure.
Go ahead and let you have the screen share.
Sounds good. Can everybody see my screen?
Yep.
So thank you so much for inviting me, and I found everything you said very valuable. I think that patients would definitely have a lot of use for your website. I know that my patients are always asking me these types of questions, so it's a nice resource to have. So, as you were just mentioning, a very common question that I get from my patients is, am I going to progress? Am I going to be okay? And how do I know if my disease is going to get worse? So I'll be talking to you a little bit about that today and hope to be able to answer some of your questions later on. So living with a chronic disease like myelofibrosis can lead to patients feeling a lot of anxiety. And that is, definitely something that I spend a lot of time thinking about with my patients, thinking about on my own when I'm trying to think about different research projects and how to improve treatment for my patients. But one of the common questions, a few of the common questions that I get from my patients is, what is my prognosis? How can you use the information that you have in front of you right now to tell me what my prognosis is? Is that going to change over time? If I have other symptoms, new symptoms, if my symptoms change, does that mean anything? How will I be treated now? And will I be treated like this forever, or will that change over time? And how do you use the information like my blood counts or the size of my spleen and things like that to help inform how you treat me and how you think about my prognosis? And so I'll help you answer some of those questions today by maybe sharing a little bit about how we as the clinician team think about prognosis and progression. And I think one important thing to recognize is that although we may have a lot of tools that help us predict progression and prognosis, these are imperfect tools. There's a lot of information we don't know yet. There's a lot more information that we have today than we had last year or 10 years ago. But there are many patients that may look for all the world like they are patients that are going to progress and then they don't. And then the opposite is also true. And so one thing that I remind my patients is that you are not a statistic. You can't progress 10% of the time. You either progress or you don't progress. And many of the studies that were utilized to help determine progression may not necessarily apply to you. I met a person yesterday that was in their 80s. Well, most of the studies that we have that help us determine if somebody's going to progress doesn't include people in their 80s, or they don't include people in their 80s. They usually include people that are younger than that. And this is true also for patients that are in their 20s. Most of the studies don't include people that are very young. The other thing too to keep in mind, and this is more optimistic, is many of the studies that have had the ability to follow patients for many years are also studies that took place a while ago that have included patients that were taken care of with different medications that we have available right now. And so although these prognostic scoring systems that I'm going to talk about that help us predict progression are useful, they do have limitations. And I think that not only are things different now in terms of what we have available to treat our patients, but things will also be different in a few years. And so I think that it is important to take those limitations into account when I'm talking to you today and when later on you are trying to figure out your own prognosis based on the scores that I'm going to talk about. So this is imperfect still, all right, but it gives us at least a framework. So myelofibrosis is not a very common disease. There are 3 different types of myeloproliferative neoplasms, or MPNs, and that includes ET, or essential thrombocythemia, PV, or polycythemia vera, and then myelofibrosis. And myelofibrosis is the least common one. Myelofibrosis can happen by itself, meaning that somebody didn't have a condition before, and that's what's called primary myelofibrosis, or it can happen in people that used to have ET or PV and then progressed to myelofibrosis. Some of the characteristics of myelofibrosis include low blood counts, also, although some patients can still have high blood counts, especially those that progress from ET or PV. Patients with MF can have what are called constitutional symptoms, or symptoms that can affect your whole body, like fevers, chills, night sweats, fevers, and itching, among others. Patients will also have splenomegaly very frequently, or an enlarged spleen. And then with myelofibrosis, there's also a risk of transformation to leukemia. So ET and PV can transform to MF, and all 3 can rarely, thankfully, transform to leukemia. So myelofibrosis is a progressive condition where it may start out as early prefibrotic myelofibrosis, where there's not a lot of scarring, and then over time, more scarring can develop. And then over time, patients will develop signs of blood being made outside of the bone marrow where it's normally made, and this is called extramedullary hematopoiesis, and patients will then develop things like an enlarged spleen or sometimes an enlarged liver. As the bone marrow continues to have difficulty making normal blood because of more scarring or fibrosis, patients will develop progressive low blood counts or cytopenias. In addition, as the disease progresses, some patients may also develop progressive constitutional symptoms. All of these things can lead to the complications that we experience in myelofibrosis, which include, discomfort from living with an enlarged spleen or liver, issues of having low blood counts like anemia, which can make people very fatigued, infections, and patients can also have complications related to bleeding and blood clots by having abnormal blood counts, especially low platelets. All of these things together can lead to reduced quality of life and progressive disability. And lastly, patients can, like I mentioned before, progress to leukemia. So how do we approach the treatment of a patient? So first, we need to assess the risk of the patient, and I'll spend the next couple of slides talking to you about the different risk factors the different prognostic risk models that we use to determine the risk of a patient, the risk of progression, and also their overall survival. So once we've assessed the risk, we need to determine if a patient is eligible for a transplant, if they desire a transplant, and what is their disease risk. After that, and I'll talk to you more about what I mean by all of these things, we assess their need for immediate therapy. Even if a patient is somebody that needs to have a transplant, they may not have it right away. It may take years. So while we're trying to figure out when they should have a transplant, a bone marrow transplant, we need to figure out, do they have symptoms right now related to their spleen? These include things like abdominal discomfort or an enlarged spleen that may cause some pain, or early satiety, meaning they get full very early. And this may be associated with weight loss as well. Or does a patient have constitutional symptoms like we were talking about before, like night sweats or weight loss or itching? All of those symptoms that I mentioned could be reasons to start somebody on a medication to improve those symptoms. And then separate to the symptoms of the disease, it's also important to try to assess if a patient has issues with their blood counts. Are they too low or are they too high? All right, so now I'll spend a little bit of time talking about what are called prognostic scores. So basically these scores are utilized to determine what risk category a patient falls into, and this then helps us figure out their prognosis. So here's kind of a summary of all of the scores that we have, and they've basically been building on top of each other. So the first one was the Lyell score, then came the IPSS, then the DIPSS, and then more recently, the DIPSS plus, or we call it DIPS plus, and that stands for Dynamic International Prognostic Scoring System. And then more recently, we have a score called MIPSS 70 or MIPS 70, and the M is for molecular, and I'll explain what that means, but that talks about genetic mutations. And there's another score called the GIPS. Okay, there is also another score that we utilize to calculate risk in patients that have previously had ET or PV, and that's the MySec PM. So I'll kind of go over these, not in too much detail, but just to give you a sense of what is used in each of these scores. And so basically, I meet a patient and I try to plug in their different blood counts and symptoms and mutations, et cetera, to say this is a low risk patient or a middle risk patient or a high risk patient. So that helps to orient me to be able to talk to my patient better, helps to figure out, is this a patient that I need to be very worried about and send them to see a bone marrow transplant doctor right away? Can it wait a little bit? Or is this somebody that really can be observed? So when I first meet a patient, I usually use a score like the DIPS plus, because that has a lot of information that I'll have readily available to me right away. Things like knowing their age. I'll know that first when I meet the patient, knowing their blood counts, etc. Whereas the MIPS score, the M stands for molecular, which means mutations. That's something that I may not have right away when I first meet a patient, and I may need to kind of recalculate their score later on. And so these scores, again, like I was saying before, not set in stone. They're not perfect predictors, but they help to orient ourselves initially to help figure out treatment for patients. They're also utilized in clinical trials to determine who may be eligible to participate in a clinical trial. So here is the DIPS score, and it takes into account risk factors like the patient's age, what their blood counts are, if they have these cells called blasts in the blood, if they have symptoms, is this a patient that needs transfusions, are their blood counts low? And the last one is a genetic question, the cytogenetics, which we don't often have for myelofibrosis patients. And so we can pretty much calculate the DIPS score for a patient when we meet them for the first time. And you can see that, low risk patients have a pretty good overall survival. And again, this is limited to the fact that this was done a while ago when we did not have a lot of therapies available, and it doesn't take into account the mutations. But it's still useful to help us, determine if somebody is low risk or high risk. Those that are intermediate to risk or greater usually are referred to transplant right away. Now, the MIPS score built on the DIPS score and uses a lot of the same factors, but it also really weighs the mutations very heavily. So if you have a JAK2 mutation versus a calreticulin mutation, these are common mutations in MF, you get different scores. And if you have additional mutations to those, then you also get additional scores. And what we've learned with time is that having more mutations is usually not better, although there's some mutations that don't actually matter or we don't know that much about them. And so many times when you first meet a doctor to evaluate you for myelofibrosis, you will have genetic testing, and this can be done both from the bone marrow as well as the blood. And then I mentioned briefly, there's a score called the MySec PM that was designed specifically for patients that had previously had a diagnosis of PV or ET to help figure out their prognosis. And as you can see, these scores are all pretty similar and include similar factors like age and symptoms and their blood counts. So again, just so that you know, this is what your doctor should be thinking about when they're talking to you. What is my patient's score? And this helps to determine, how we treat them and if we refer them to transplant. Okay. So there's so many scores. Yes, correct. How do we pick one? Well, everybody's a little bit different. And I think really the message that is important as a patient going to see a doctor is, are you using a score? That's the first thing to do. It's important to ask, are you using a score? How do you use them? Well, I told you how I do that. I use the score like the DIPS score that has a lot of clinical information that's readily available to me. And then I'll use the MIPS score once I have genetic information because I find that to be more accurate. Now, if I fall into one category, does that mean that I'm that category forever? And the answer is no. This can change over time. Unfortunately, the answer to that is that it usually gets worse over time. People usually don't get better over time. Should I calculate my own risk? Well, that's a good question. I would say that it's not a bad idea to think about doing that, but I would usually recommend that you do that with your doctor so that you can then be with somebody that can help you understand what it means and that you can make a plan based on that information. Otherwise, I think that just doing that by yourself is probably anxiety provoking. And so I would recommend doing that with your doctor or healthcare team. And then what do you do with that information? As I was mentioning before, using that information can be helpful for many different things. One, to just give you a sense of prognosis. Another, with all the limitation that I mentioned before. Another is to say, hey, listen, I think that I'm on the higher end of the spectrum here. I think I have a higher risk disease. I have not been sent to see a bone marrow transplant doctor. I'm not sure that I know much about bone marrow transplant. That sounds kind of scary, but maybe I should ask to have a referral to a bone marrow transplant team. Honestly, it's difficult for doctors sometimes to know if you're a candidate for a transplant or not. In the same way that therapies have improved significantly for the treatment of myelofibrosis, caring for patients that have undergone a bone marrow transplant, which is the same thing as a stem cell transplant, has also gotten so much better with time. And so don't assume that because of your age or because of a medical problem, etc., you may not be a candidate for this therapy. I think the best thing to do is just to ask for a referral. The worst thing that can happen is that they say that you're not a candidate or that right now is not the right time. So you can use that information to also help guide your therapy. All right, well, this chart is a little bit complicated, but it's just my approach to how I treat myelofibrosis, at least in 2025. And so, like I said before, I'll use a score to divide up, is a patient very low risk, intermediate, or high risk? And then I figure out, does my patient have symptoms, either from their spleen or systemic symptoms, or do they have issues with low blood counts? Patients that don't have any symptoms, whose blood counts are fine, whose spleen is okay, they can be observed. Those that have an enlarged spleen that's bothering them or have other symptoms like fevers or itching or sweats should be considered for a medication in the category of medications called JAK inhibitors, and I'll talk to you about those a little bit more. And we can choose the different JAK inhibitors based on the blood counts of the patients. Patients that have low blood counts should also be considered for therapy, and we have several different medications that can be utilized to help manage the low blood counts. And patients that are high risk or very high risk really should be evaluated for transplantation. So a very common medication that we have for the treatment of patients with myelofibrosis is medications called JAK inhibitors. So I'll talk to you about the 4 different types, but one thing that's important to recognize is that patients are eligible to receive these types of medications even if they don't have a JAK mutation. So the most common mutation that patients will have is the JAK2 mutation, but you can be eligible to receive a JAK inhibitor even if you don't have that mutation. If you have a calreticulin mutation, for example, you can still receive this therapy. So JAK inhibitors are pills that help to block a pathway inside of cells that's turned on all the time in patients with myelofibrosis. And these medications help to improve the spleen of patients. So on the left side of the screen, you're seeing a very enlarged spleen of a patient in a CAT scan. So they help to reduce the size of the spleen, and they also help to improve symptoms. If you're not sure if you have symptoms, I recommend filling out a myeloproliferative neoplasm symptom assessment form. This is something you can look up online very easily, but it includes things like energy, abdominal discomfort, and symptoms related to having a big spleen, night sweats, itching, having bone pain, not joint pain, not arthritis. We're talking about bony pain, fevers, or losing weight without trying, which usually gets a chuckle from my patients. So patients that have either spleen or symptoms are eligible for JAK inhibitors. And we now have 4 different JAK inhibitors. So the first one to be approved was in 2011, that's ruxolitinib. And after that came fedratinib and then pacritinib, which is approved for patients with low platelets. And then more recently, we had the approval of a drug called momelotinib that was approved for patients with anemia. And so what's exciting about pacritinib and momelotinib is that they can be used in patients with low blood counts. Pacritinib and momelotinib have also been demonstrated to improve hemoglobin in about a quarter to a third of patients. Once I'm treated, what do I do and what do I look out for? So once you get started on a treatment, or even if you're not started on a treatment, you're just under observation, it's important to monitor blood counts and make sure that there aren't signs of progression. What does that mean? Are my blood counts changing or are they staying the same? When they stay the same, that usually means that you're not progressing. But fluctuations in the blood counts are normal, but big fluctuations or a trend in one direction or another could be an indicator of progression. Are there cells in the blood that don't belong there? One of those is called a blast, and having a lot of these blast cells is a sign of disease progression, for example. Another thing to keep in mind is, what's the spleen doing and what are the symptoms doing? Was the spleen previously well controlled with the medication and now it's not? That may be a sign that your disease is progressing or that you're not responding to the medication that you were on before. Symptoms is a difficult one, and patients get very nervous about this while they're keeping track of their symptoms. I would say that symptoms don't necessarily equal progression, but if you had no symptoms whatsoever before and then all of a sudden you have a lot of new symptoms, that may be concerning, and it would be important to talk to your doctor and get your blood counts checked. Now, the next question is, do I need a change in therapy? When we just had one medication, which was ruxolitinib or Jakafi, well, that's all we had. And so if you weren't eligible for a bone marrow transplant and you were on ruxolitinib, that's all the therapies that we had. But now we have 4 different JAK inhibitors, in addition to a lot of clinical trials and medications that can be utilized to help low blood counts like anemia. And so it's important to not just get on a medication and stay on that medication forever. And so a group of investigators did a study looking at patients treated with ruxolitinib specifically, and they said, how do patients do with this medication? And they found out that if after 3 or 6 months, patients on ruxolitinib ended up on a very low dose, if their spleen hadn't shrunk, and if they were needing a lot of blood transfusions, those factors could help predict who was going to do well and who was not going to do well. And so, not to go into all of the details of this study, but just to kind of let you know that there are scores that your doctors can use or data that your doctors can use to say, you've been on ruxolitinib for 6 months and you're on a low dose or you're needing lots of transfusions. We should probably do something different. So maybe at the beginning of treatment, you were not considered for transplant, or maybe at the beginning of treatment, we thought that ruxolitinib was a good choice. But now that you've been on it for 6 months, it's good to take a pause and say, is this really working out well for you? And is this the best medication for you? We have a score that we can use to help us determine prognosis, but also, to be a good time to discuss with your doctor, maybe I need another therapy. And so just because you start on one therapy doesn't mean you have to stay there forever. And just because you start out with one number that's calculated from the risk calculators that I was talking about doesn't mean that you're going to stay there forever. So things change, and it's important to ask that to your care team. So again, along the lines of, do I need a change in therapy? So in addition to that model that I showed you called RR6, in general, if your spleen or your symptoms or your blood counts are not well managed, then it's a good time to talk to your doctor about maybe needing another change in therapy. And that could be another JAK inhibitor like the ones I mentioned. It could be a clinical trial, or it could be considering a bone marrow transplant. So just because you're on one medication doesn't mean you should stay there forever. So in summary, we have different risk scores that can help calculate prognosis and progression. Remember that these are imperfect. They were developed before we had a lot of the therapies that we have now. So it's just a general idea. It is not a promise. It's not set in stone. These risk scores can change with time as blood counts change and symptoms change. So we use these scores to determine prognosis, and we primarily use them to determine who needs a bone marrow transplant referral and who does not. We're not perfect at determining progression, but changes in blood counts, changes in spleen, sometimes changes in symptoms may indicate progression. So these are the things that you and your doctor should be looking at whenever you see each other. Come prepared to your doctor's visit. This is something that I always like to talk about. And this helps you to understand your risk and to make sure that you leave your doctor's visit with all the information that you need to answer these difficult questions sometimes. So when you go see your doctor, do you know what your blood counts are? Did you discuss that with them? Do you know if they were stable or did they change? Is there anything that was worrisome in those blood counts? And so make sure that you ask about that. The next thing is, if you are on therapy, is that therapy working? Is your doctor happy with what that therapy is doing? Are you happy with that therapy is doing? Is it improving your spleen, your symptoms, your blood counts? Make sure that you understand why you are being treated with a medication. So being on a JAK inhibitor is not a requirement if you have myelofibrosis. You should be on a JAK inhibitor if you have a reason for being on it. And so it's important to ask your doc to explain to you why you're on this medication so that you know what to look out for. If you need a new therapy, make sure that you understand why. Is it because of worsening disease, because things are getting worse? Is it simply because you didn't tolerate it, you had a bad side effect? Or your spleen wasn't shrinking as much as your doctor or you would have liked. So make sure you understand that as well. And then the other thing that I've mentioned a few times, and I'll mention this one last time, is has a referral to bone marrow transplant ever been discussed with you? Don't assume that because of your age or your medical conditions or where you live, you are not a candidate for this. And so if you've never brought this up with your doctor, it's a good idea to at least ask. Even if, the answer is, your disease is very low risk, you don't need that right now, don't worry about it. It's fine. It's important to at least ask that question so that you know and make sure that nothing is being missed. And that's all I have. Thank you so much for your attention.
Thank you for that awesome presentation. I really liked the phrase that you used. You are not a statistic. I think that's a really good one for people to keep in mind of this isn't, we don't have an exact science on predicting progression and everyone is different. So you are not a statistic, I think is a really good takeaway from this presentation.
Thank you.
So now is the time for questions. So if you have any questions that you'd like to ask Dr. Hobbs, feel free to drop those in the chat and I'll go ahead and read them out. If you're watching on YouTube, you will need to hop over onto the HealthTree website and join the Zoom call in order to ask your questions there. But something that I noticed that I had a question about was I noticed that on the MIPS, being red blood cell transfusion dependent is not actually included in that score, and that really surprised me. So, because it is included in lots of the others, does that mean that red blood cell transfusion has not been found to be helpful in predicting progression, or it's just excluded from that scoring system?
Each of the scoring systems end up, determining what ends up being statistically significant in that group, which just kind of highlights some of the limitations of these scores. The MIPS does have two different questions about red blood cell number. So one is moderate anemia defined as a hemoglobin of 10, and then another one is more severe anemia defined as a hemoglobin of less than 8. And
Okay.
so those transfusion dependent patients are probably going to be included into that. And so it is counted, it's just counted in a different way.
Okay.
Yeah,
Gotcha. I
great question.
must have misunderstood that part.
No,
All
not at all.
right. Next question comes in from Darlene. How often are you recommending interferon-based drug treatments such as Pegasus or the new Bezremi?
For myelofibrosis, neither of them has really been, well, Pegasus is we borrow, but roping interferon is not approved for myelofibrosis. And the data are limited in general for the utility of interferons, whether that be Pegasus or roping interferon for myelofibrosis. I would say that there's some studies that maybe show that for early myelofibrosis, it could be helpful, but we don't have definitive data, and this is important, to show that giving interferons will prevent progression of myelofibrosis that already exists. We don't even have definitive data to say that patients with PV and ET treated with interferons won't progress to myelofibrosis. And so I don't utilize that for myelofibrosis that much. Occasionally for early myelofibrosis, it could potentially be helpful.
Okay. And then next up, does the kind of gene mutation affect prognosis, like a MIPL versus a CALR versus a JAK2? Have studies looked into trying to figure out perhaps what specific mutations may lead to increased risk of progression?
Yeah, great question. And so the MIPS score does give different scores based on mutations. And so, although not as dramatic, there is a different score, a different prognosis for patients that have a JAK2 mutation, which is a worse prognosis from a myelofibrosis perspective than having a calreticulin mutation. Little is known about the MPL mutation, but really the ones that give the most points or are associated with the worst prognosis are not, whether or not you have JAK2 or CALR, it's the other mutation. So things that are called high molecular risk mutations, and that's included in the MIPS, and that includes mutations like IDH, ASXL1, SRSF2, and others.
Okay. And then this one is another one related to mutations, but this is looking at TP53 mutations. Um, and are T is TP53 mutations included in any of these scoring systems? And then are patients that have a TP53 mutation, are their treatment plans different, or has that not really been factored into this equation quite yet?
What a great question and super relevant. At this past year's American Society of Hematology, there were several presentations reporting on the outcomes and prognosis of patients with P53 mutations. I think that because they're not that frequent, they didn't end up being statistically significant, and that's why they weren't included in the MIPS score. I would imagine that eventually they will be included. The MIPS score has been updated, and we now have the MIPS version 2 that includes another mutation. So I usually consider P53 mutations as poor risk mutations, even if they're not included in the MIPS score. Again, highlighting some of the limitations of these scores. We know that patients with these mutations usually do have a worse prognosis, especially if they transform to leukemia. Unfortunately, and this is true not just of myelofibrosis, but of all leukemias in general, there aren't any therapies that have been shown to target P53 specifically, to help P53 specifically. But I do try to be a little bit more aggressive in my management of P53 mutant patients. And so those are patients where I'll try to get them to transplant sooner rather than later if I can.
It's good to know. Next up, do you consider allele burden, if available, as a factor in progression? I've seen varying statistics on this.
Not yet. Not yet. We know that maybe patients with higher allele burden will progress more, like from the chronic MPNs to myelofibrosis. But we also know, for example, conflicting data where patients with low allele burden may have worse myelofibrosis outcomes. So that's like what's called the cytopenic MF or myelofibrosis patients that have low blood counts. They actually oftentimes have very low JAK2 allele burdens, and they do not have better prognoses. And so I think we really still don't know how to use variant allele fraction to determine prognosis. And importantly, getting to your question, how to utilize changes in variant allele fraction to determine, changes in therapy and things like that. So that's something that I think we'll see probably change in the next couple of years as we get better information on how to utilize that information, and hopefully, even more importantly, as we get therapies that actually are able to impact those mutations consistently. Because the JAK inhibitors that we have right now really don't get rid of those mutations consistently.
Mhm.
And so we really can't use the variant allele fraction a whole lot.
Okay. And then this one, I'm going to ask it and then also rephrase it a little bit to be a little bit more inclusive. But is the age of 71 considered to be too old for blood transfusion? Is the general or like the more specific? And then the more generalized version is how should patients go about adding some of this palliative care, like blood transfusions, adding some of these? It might not be a JAK inhibitor, but how should they speak to their doctor about maybe trying to find something that might help with symptom burden?
Okay, so to answer the first question, kind of goes in line with what I was saying before. Don't make any assumptions about whether or not you're a transplant candidate. Like everything in medicine, thankfully, we've gotten better at a lot of things. And so, a few decades ago, we probably would not have even considered transplanting somebody in their 60s and then, in their 70s. And now, really it's a case by case thing. In the same way that we have scores for myelofibrosis, there are scores for transplant outcomes to predict transplant outcomes. And they don't actually include age because age has not been found to be the main factor that impacts outcomes. And so, to answer generally, no, 71 is not too old. Now, there's lots of variation in 70-year-olds, right? We can have a 70-year-old that's hiking every weekend and very active and still working and has no medical problems. Or you could have a 50-year-old that has had like 5 heart attacks and has kidney failure and uses oxygen to breathe because they have emphysema. So, you realize that it's not really just the age, it's a bunch of other things. So just because you're 71 doesn't mean that you're not a transplant candidate. And then the next question about palliation of symptoms is super important. Myelofibrosis is a unique disease for many reasons, but unlike many areas of hematology and oncology, the drugs that are used in myelofibrosis were not approved because they make people live longer or because they cure their disease. They were actually approved because they're great palliative drugs, because they improve symptoms. So getting drugs approved in MF is really because they help to make people feel better and get rid of their symptoms. Now, if you are a patient that has tried the JAK inhibitors, they're not working for you, you still have a lot of symptoms, and they're not getting better with treatment, I think it is really important, and we probably underutilize this significantly, but it is really important to talk about, what can be done to help me feel better, and would a referral to something like palliative care be appropriate to help manage some of my symptoms? Because even if your doctor may be an expert in managing your myelofibrosis, the palliative care doctors are expert in managing symptoms. And so I think there's only benefit to the patient to have, that involvement in their care.
Okay. And then just for anyone listening, if you are interested in learning more about transplants, we did a webinar with Dr. Palmer out of the Mayo Clinic about 2 weeks ago. That should be up on our website currently. That was focused on bone marrow transplant for myelofibrosis patients. So that's a really good resource that if this is a question you have or you want to learn a little bit more about the bone marrow transplant process, highly recommend that you go check that one out because it is a very good resource. This one's a pretty specific one, but the scientist in me is a little curious on this as well. Is SH2B3 known to affect progression of CALR? So more just
You mean like the
different.
subunit in JAK2 that's muted, or I don't specifically understand that question.
Let's see. Uh, Terry, would you mind putting in another, just clarifying that one a little bit more? Yeah, mutation of SH2B3.
I don't
So
think a whole
just
lot.
more specific.
That has not been associated with progression. Also, it's not usually one of the mutations that we normally see in MPNs. And so, if you have a rare mutation, it probably just hasn't been associated with progression because it's just not something that we see that often.
All right. And I think you've done, I'm trying to come up with any other questions for you,
Sure.
but I think you've done a great job answering all of these. If anyone else has a question, I'll give you another moment to get those in. But I just wanted to say thank you so much for taking the time to join us today. This was super informative and uh, it was great having the opportunity to speak with you.
Thank you so much. I really appreciate the invitation.
Great. All right. Well, looks like we are done with questions, so we'll go ahead and move on. So before we go, I'm going to highlight the Track My Disease feature on the HealthTree Care Hub. Um, Once you've connected your medical records, you can use the Track My Disease feature to provide you with the ability to gain one of a kind access to your health information, encompassing things like lab results, your genetic profiles, and treatment histories, offering you with invaluable insights into your own medical journey. On the screen, I have the link to sign up for the HealthTree Care Hub. Um, and I'll also include a link in the follow-up email. If you have any questions or troubles connecting your records, you can reach out to our patient navigators and they'll be able to help you through all the steps. And before you go, I want to just let you know about a couple of upcoming events that I have scheduled. So on April 4th, we're going to be doing a roundtable, and this is going to be looking at a similar topic to today, but in a little bit more depth. But how is myelofibrosis staged? We're going to be hearing from Dr. John Mascarenhas, Dr. Rajit Rampal, and Dr. Lucia Masarova for this one. And then on April 15th, so just a couple weeks after, we're going to be talking with Dr. Alexander Koltov. And this will be kind of a getting up to speed 101 basic type of thing for newly diagnosed with myelofibrosis. So really just a good catch-all informational webinar. All right. And finally, I just want to say thank you all for helping us build our myelofibrosis community. Thank you, Dr. Hobbs, for joining us today and giving that wonderful presentation. And then I've added my email to this slide. Please don't hesitate to reach out to me if you have any questions about HealthTree or any of our programs, or even if you just want to chat with me. I'm always available. I appreciate you all, and I hope that you have a great rest of your day. I hope to see you at another webinar soon.
Thank you.
Thank you.